I will speak about the sequence and methods of reconstruction for severe lesions of orbital and adnexa. We had started the session with the reconstructive surgery, and we shall end it with that, with this topic. It is very serious and it's complicated and very important for well-being and for good results of quality of life. In severe trauma with complicated lesions of orbit and nexa, it's very difficult to change, and to assess. So the main questions when we see the patient is what line should be chosen. And the first line is to save the eye and make all adnexal tissues and structures with good function and morphology, to save the eye and enable good vision. And the second line is connected with artificial eye, with eye prosthetics, and that line is following the rules of eye prosthetics to form the cavity, the orbit, the stump, the fornices, to ensure proper form, proper position of the eye, artificial eye. And these two lines are main features of managing these patients. The first line predisposed to keep safeness of the eye, to keep it functioning. This means to eliminate leg of thalamus, dystrophy, ptosis, strabismus, and motility of the eye globe. While the second line predisposed for artificial eye prosthetics is aimed at achieving proper position of the prosthesis, that is the reconstruction of the socket, the fornices, the stump, and the eyelids, to cover and ensure proper position of the eye prosthesis. А сейчас есть?
Да, есть.
Хорошо, начинаем тогда. Сейчас есть? Картинка видна? Павел Александрович.
Да. Картинка видна, сейчас хорошо, да.
Хорошо, все. And in recent times, we meet with one more option, that is preparing for the eye globe for keratoprosthesis. This is not an ordinary thing, because most complications connected with the keratoprosthesis are extruding of the device and ophthalmitis. So the third line is concerned with the preparing of the eye surface, of the thickening of the sclera tissue of the corneal surface to ensure a good position of the eye prosthetics. Before we start with the reconstructive surgery, we must anticipate some actions to pre-reconstruction stage. If there is any infection, abscess, or dacryocytis, we have to eliminate those infections. If we have a leg of thalamus, first of all, we must ensure a good covering of the eye globe to eliminate leg of thalamus, and then to anticipate all other stages of reconstructive surgery for the orbit and eyelids. If there are foreign bodies that are in the way of the surgeon, which mix the tissues and don't allow to make proper surgery in the soft tissues, the foreign body should be removed. And finally, when the orbital roof is distorted, when we have the defect of the orbital roof, we cannot operate on the orbit if there is a herniation of brain tissue into the orbit. That is why we have to consult to the neurosurgeon and contact with the neurosurgeon to ensure good solid protection of the orbital cavity from the cavity of the brain. It's very important and challenging. In the line of eye prosthetics, it is important to time the removing of the waterless eye. When should we remove it? If uveitis is positive, is active, we have to remove the eye as soon as possible. If uveitis is negative, if we don't have any suspicion of intraocular inflammation, we prefer to reconstruct, to eliminate the eye and reconstruct the stump after orbital reconstruction. As soon as possible, it's beneficial for eliminating of the eye because the sclera is not so deformed. It may be shrinked, but it can be expanded not so difficultly. And early evisceration is beneficial for eye prosthetics. You can see the early case with eliminating of the eye with evisceration and performing the good orbital stump. Evisceration as a method of elimination of the eye is preferable against enucleation, even in the case of distorted sclera. You can see the shrinked scleral cavity, the remnants of the eyeball, but the eyeball was not removed. This is the consequence of the severe trauma, and there were no attempts to eliminate the eye. But the deep atrophy of the eyeball is present. Even in this case, we have an opportunity to make evisceration and form a good stump, a good form of the cavity, a good support, a good pillow for the eye prosthesis, preserving the sclera. Orbital implantation in removing of the eyeball is obligative in almost all the patients. I cannot say that in all the patients because there are some severe types of trauma which demand enucleation, elimination of the eye without orbital implantation. I can show you this clinical case. A boy suffered from the shot of the traumatic pistol with the rubber bullet. The dimensions of the rubber bullet is 12 to 25 millimeters. The bullet crushed the roof of the orbit and stopped at the end of the cavity. In this case, we have prominent herniation and deformity, distorted tissues in the orbit, and implantation of some material into the orbit will be harmful. The stump will be very prominent and will not, we cannot fit prosthesis, proper prosthesis in this cavity. The orbital stage is one of the first stages for complex reconstruction, where anticipate the reconstruction by two ways. One way is soft plaster, and the second is hard reconstruction. The orbit is a framework for soft tissues, for the eye globe, for hypertensive. So first of all, we have to form, to shape the framework of the orbit. Soft plaster means that we put flexible materials over the depressed bone. For example, in this case, we put the PTFE plate over the depressed orbital bone. It is filled with a carbon felt, the empty portion of the cavity. The hard reconstruction means that we use titanium implants to form orbital framework when we have no opportunity to put the soft membranes in the orbit, which will not stay in place. Here you can see the stereolithographic model of the orbits and individually modeled titanium plate, which we used to put in the at the bottom of the orbit. Here we use the same lithographic model to adapt soft silicon plate. You can see the previous attempt to reconstruct the orbit with the use of titanium plate, and we anticipate further reconstruction, further filling of the cavity with soft plate. The sample of hard reconstruction, we use several titanium plates almost all around the orbit, all around the edges of the orbit, to make the proper framework for the soft tissues. The process of individual modeling looks as it is. First, we take CT scans and send them to the company which deals with the titanium plates. This is one of the models of the titanium plates. These are the drawings according to our needs, and these are the pre-modeled titanium plates fitted in the orbit. We can do without individual plates in sometimes, so we can use standard plates which are designed for orbital reconstruction. This is a trapezoid titanium plate which we can easily shape, but it has very big holes of big diameter. So to prevent soft tissue drop into that holes, we used to cover it with a thin soft membrane, so to ensure the isolated lower wall of the orbit. The next stage is the stage of soft tissue reconstruction. We can operate in plastic surgery only with good soft, thick soft tissue layer. If we lack soft tissue, we cannot do anything, any transplantation, any moving of the skin, any moving of subcutaneous tissue, and to restore muscles and anything else. So we use dermis and fat grafts to fill the intercutaneous, subcutaneous tissues. Like in here, the lower eyelid is elevated after dermis fat grafting on the lower edge of the orbit. And here in this case, it was very difficult to fill all the parts of the defects of the orbital fractures, but the condition was improved, and it was made possible to anticipate further reconstructions of the eyelids. Canti are major fixing points of eyelids, so we have to put the angles of the eye in the proper position. After that, we can move to reconstruction of eyelids themselves. If we follow again the line 1, which is connected with eye prosthesis, we have to reconstruct the socket. In many cases, after, like here in gunshot injuries, the cavity is absent, and there was made an attempt already to fill it with a skin graft, but it was failed. The best material for reconstruction cavity is a mucus graft. And here you can see the cavity reconstructed with these grafts with good prosthesis. Mucous membrane of the oral cavity is the best material for modeling the cavity for the eye prosthesis. You can see the locations of harvesting and donor grafts of mucous membrane. And here you can see the 4 grafts which will be placed around the artificial eye and put into the cavity. The sample at the next stage of the reconstruction is orbital implantation. After we make the framework, after we are sure that there is place for prosthesis to stay in the orbit, we have to assess the necessity and possibility of orbital implantation in the center of the orbit. Here you can see the deep anophthalmos with the empty cavity, and on the next after the surgery, the orbital implant is inserted in the center, is located in the center of the orbit, and the overall picture looks much better. Here is the city modeling, three-dimensional visualization of the orbit. First, after modeling of the framework of the orbit, and then the result of the orbital implantation where the eyeball is absent. This is the stage of orbital implantation. When we anticipate the line 2, the functioning eye, we have to make safeness for the eye globe to make it to keep it functioning. This is the stage of eyelid reconstruction. Usually, this is a multi-step procedure. You can see this patient who was treated for several years. First of all, he was admitted with some thin layer graft transplant on the bones. After several surgeries, multi-step surgeries, we gained a more perfect result. The residual leg of thalamus is about 1 millimeter. Is not very essential, but is rather essential. So the next step will be needed maybe for eliminating all this 1 millimeter leg of thalamus. In the case of eye prosthetics, we have to reconstruct the eyelids so that to ensure their position, the proper position of the eye prosthesis in the orbital cavity. And as usual, it takes several stages. You can see the deformed absence, of the eyelids and the absence of the cavity, and the result of almost properly fixed canti and reconstructed eyelids with a rather perfect position of the artificial eye. Again, we go to the line 2, the functional eye. The strabismus is a real challenging problem in complicated trauma. Restricted muscles are very difficult to act, to do, to operate, in order to make good, to ensure good position, good motility of the eyeball. And not every muscle is able, even if we take off the muscle out from the fractured bone, it can stay rigid, not elastic. So it's not very often in severe trauma. We can achieve excellent result in eyeball motility. We release the muscles from the restriction, from the fractures. We make muscle substitution with neighbor muscles. We perform recession resection, and as an ordinary common strabismus surgery, and we use Botox as an aid in the problems of reconstruction of strabismus. Here you can see the sample of stage of strabismus and eyeball motility. The severe acid deviation, paralytic acid deviation with full absence of musculus abductus. And the result of the surgery, strabismus surgery, with good straight position of eyeballs, but nevertheless the motility of eyeballs is rather restricted. Next, after strabismus surgery, we anticipate the possibility of eliminating of the eyelid ptosis, upper eyelid ptosis. In this case, we use methods of levator reconstructive surgery and brow suspension. The main topic, the main predisposition is that we must avoid leg of thalamus, especially in the case of restricted operated on strabismus, because in small leg of thalamus we can get keratopathy. And here you can see the rather good results of reconstruction of the levator muscle and functioning eyelid. If we see a patient from line 1 that is with eye prosthesis, we may not follow strictly to the avoidance of the leg of thalamus, because eye prosthesis can stand for that. If eye prosthesis is in the condition of leg of thalamus is constantly open, we can wet it with some ointments or liquids, and we don't care about the keratopathy after that. And in the case of anophthalmos, it is useless to use brow suspension. So every now and then we use levator surgery to open the eye, and we can anticipate the surgery that is rather dangerous for the open eye, but not so dangerous for the eye prosthesis. In functioning eye, at the stage of lacrimal drainage, we must try to reconstruct the lacrimal passage to the nose. It includes canalicular restoration, LACA canaliculostomy, LACA cystostomy, LACA rhinostomy, or DCR. All of the methods are not so very easy, especially in traumatic cases with surroundings of scar tissue. But we can anticipate to assess the possibility and may anticipate our steps, surgical steps, to make the restoration of the lacrimal passage. Here you can see the distorted nose, the broken nasolacrimal canal, and the results of reconstruction, which ended perfectly, is the lacrimal drainage is restored. You can see the lacrimal probe in the lacanasal stoma. And see, you can feel that all the stages are multiple, and the whole treatment takes a good amount of stages. Here you can see a sample of almost 6 years of reconstruction, beginning with orbital reconstruction and ending with eyelashes transplantation. This is hypothesis. We get leg ophthalmos, and the blinking is very poor because the restoration of the muscles, especially of the musculus orbicularis oculi, is very difficult to make it act, to make it contract. And that is why leg ophthalmos is obvious in most cases. In the conclusion, we have several positions. That first of all, we must choose the proper line with the eye or without the eye. And then we have to make framework, the hard orbit. Then we make fixing points for eyelids. Then restore the eyelids. Restore the lacrimal pathways. And for the final stages, need cosmesis. We have to eliminate slight little scars, little deformities of the landscape of eyelids, and so on. And finally, many years pass after all when we can drop our hands and say that it's all what I could do. So thank you.